Welcome back to the session. Attention everyone, welcome back to the session. We have Professor Iqa Altice from Yale School of Public Health and Yale School of Medicine for the next lecture. Professor Iqa Altice needs no introduction. It's over to you.
Thank you, Ramana. It's really exciting to hear everything that we've been learning today. I've actually already learned so much. I have to say congratulations. Rasta was one of our first students, and what a tour de force presentation that she gave, and it's just really a product of the excellent training and the people we're able to attract into the program. And then of course I always learn from Donna. One of the things I will say is that if you are going to do implementation research and you're going to have anything that's biostatistical, you want to go to your biostatistician at the beginning, not whenever you get into trouble later on. Involve them early on if you possibly can. I'm going to shift over to implementation strategies because Rafsta really introduced the idea of evidence-based practices and evidence-based practices. But part of your whole work that you're doing is you're really sort of setting up your work in stages. So really, you have to goal set, clarify your vision, define the problem. What is the problem? What is the implementation gap? What do you want to do short term? What is your pre-implementation activities? What are you going to do during implementation itself? Identify the processes of how to accomplish your objective. How are you going to do those sorts of activities? And customize the process, for your staff and for individuals involved. Analyze, do some landscape analysis, understand what is the implementation context that you're doing your work. And then, of course, formulate your strategy. In other words, figure out what you're going to do in order to solve it. So you have to understand what are the existing and needed resources, considering alternative plans, selecting combined strategies if you need to. And that's really where this part of the talk is going to go into. And there'll be other presenters who will go into the implementation of your sort of strategies, as well as some of your evaluation and things that you need to control for. There's going to be some slides, whether it's the 17-year odyssey or other things, that are going to be repeated because it's really important in implementation science. But Jeff Curran really sort of helped me sort of differentiate all these terms like evidence-based practice or evidence-based intervention, or what is the innovation that we're doing. That's the thing that we're doing. So whether it's antiretroviral therapy, pre-exposure prophylaxis, or even a behavioral intervention to reduce HIV transmission. What we're going to be spending some time today is talking about the implementation strategies, which is the stuff that we do to help people or places do the thing, prep ART better. And this might be sort of changing to a virtual delivery, task shifting, or something like that. And then the main implementation outcome is how well we do the thing. So if we've got an implementation gap of 68%, do we reduce that to 48%, for example? And part of the way that we think about that is, do we have fidelity to whatever it is that we're doing with our implementation strategy, or it might be a patient-level outcome in these hybrid trials, such as treatment adherence. So what are these implementation strategies? They're actions or activities to increase the adoption, implementation, or sustainability of the evidence-based practice. So in other words, it's the things that we're doing in order to make a change. So it's how we're doing it that's different. So if the standard of care is that we have an in-person related intervention and we move to a virtual one, do we stick to it the same way? Do we deliver it? Do people learn the same way? And are the outcomes any different? And remember, Donna had her 3 R's, which I thought were really excellent. But I sort of think of implementation is, do we do it better, faster, and cheaper? And if 2 of those remain the same and 1 of them is better, you're actually moving in the right direction, right? And so what we also have to think about is oftentimes we have to combine our implementation strategies. So if we have an HIV treatment cascade where we have to diagnose people, we have to link them to care, we have to engage them into care, we have to get them to take their medicines and achieve that final outcome of viral suppression, we might have to use different kinds of implementation strategies to bundle them together, because we've got multiple levels of stakeholders. And I think everybody's talked about things that are all the way out of the policy or affecting the individual. And one of the ways that I sort of think about how to frame that, especially during my pre-implementation work, is really looking at the socio-ecological model in order to think about this. Now, when we go through some of the taxonomy of these implementation strategies, you can have a discrete strategy. It can be a single thing, HIV counseling and testing. So it can be something very, very simple. So a process, you can institute something like reminders. Oh, I forget. That's a quick little sort of discrete implementation strategy. You can provide audit and feedback. If people think that they're doing the right thing, oh yeah, I already do that in clinical practice, but in reality they don't. They might need that kind of reminder. So, you were able to screen, 73% of your patients. What might it take to do better? And they go, oh, I thought I truly screened everyone. This is often what happens in clinical care. Educational sessions or workshops, any of these sorts of things are a single discrete strategy. But oftentimes, we really have multifaceted strategies, and that's really where much of implementation science is moving. So it's really a combination of multiple strategies, and sometimes we think about strategy A versus strategy B, or strategy A versus strategy A plus B, in order to really sort of come up with some multifaceted sort of implementation strategies. And then increasingly, there are these sort of blended, multifaceted strategies that have been protocolized or often branded. So whenever they're put together, and there's a whole package of these sorts of things that go together. There's the ARC LOI, which is well known. You're going to hear more either today or tomorrow. I think today on NIATx is these bundle of implementation strategies and tools that help us do the evidence-based intervention better. So these things can often come together. They're protocolized. They've got a lot of sort of sheets and sort of protocols and activities that are really sort of well organized, and they're available for you on site. So one of the examples of a multifaceted strategy was really to ask the question, can learning collaborative support implementation by rewiring professional networks? And what they were really doing is they were looking at trauma-informed cognitive behavioral therapy. And they really wanted to know if it really had an impact on sort of the way that there was advice seeking between clinicians, and whether it impacted the practice. So it involved a number of different things, such as training experts with technical knowledge. We'll learn about that later on, as education and training. Peers from other participating organisms, expert advice from outside your organization, a type of collaborative learning. And then colleagues from within your own agency who provide social professional support, which is stakeholder relationships. And it has a number of things that you use in your preparatory work. How do you sort of plan for your work? What's the active learning, bringing people together and learning from each other through collaborative learning? Supports, how do you give people reminders and to give them support in order for them to have the confidence that they need in order to do the work? And then some enhanced features such as coaching calls, checking in, having sorts of activities to change the work that they're doing, and having professional experts to make on-site visits. So it's a whole bundle of certain packages. And you'll hear more about NIATx and those bundle of implementation practices later on today. Now, as we begin to think about our implementation strategies, we need to have a nomenclature for them. And really, Byron Powell really took a whole group of implementation experts and brought them together to really use the Delphi method in order to really come up with this taxonomy. And it was a huge process, and it's still in evolution today, and it's moving with some moving parts, but I'm going to walk you through just a little bit of this. And what they were able to do, and they pulled together through it was a series of Delphi methods in order to really sort of idea and concept map. And concept map is one of the ways that we actually do our pre-planning for our implementation anyway. But to really identify 9 clusters of implementation strategies. And part of the problem is that we use a lot of different words for things, and we mean the same thing. And so what they did was they tried to give us words that we can actually use to identify what those strategies are. And they pulled together 73 strategies. They grouped them in. They sort of did the concept mapping, which is one of the strategies even for planning your sort of work, and came into these particular 9 clusters. And they're useful whenever you're planning your grant, so that when you understand what the barriers and the facilitators are, which one of these implementation strategies might have some evidence in order to really make you do what you're doing better, faster, or cheaper. These are all within this paper. By the way, the slides will be available for folks later on if you'd like them. For those who actually are released, my slides are all open access. And what in a separate paper that was done, they really identified these kind of groups of clusters. So using evaluative and iterative strategies. One of the examples is audit feedback that you might use. For instance, if clinicians really think, oh yeah, I already do that already, but in reality they don't. So sort of like saying, oh, you got 73%, what can we do to move you to 80, etc. Sort of adapting and tailoring to the context. We'll talk a little bit about that. But some of these strategies that you might be doing, you might need to tailor to sort of a new area. Training and educating stakeholders, it's one of the sort of the important things that you need to do in order to make sure that you've got folks that are speaking the same language and understanding to make sure that they have the right confidence to do the work that they need to do. And so there's ways to do that. We use Train the Trainer, just giving out educational manuals, online training. There's a number of different ways to sort of do this. Engaging the consumers. And, for instance, if you don't have people who are coming in and getting, tested, things like crowdsourcing, so you're engaging them. You're bringing them in. Social media campaigns might be examples of that. Changing the infrastructure, either by changing the way that things are done within your organization, reorganizing the electronic medical record might be a way to do that. Change the record systems, etc. So these are ways to do this, or even move things around within your organization so that things can be accessed more quickly. There's a number of others that are as well, such as providing interactive assistance. Facilitation is a more sort of expanded way that we often use for the term coaching. How do you coach people through them? Facilitation might be using some different methods to motivate people to do the work. Develop stakeholder interrelationships. When you're trying to do something and it requires people to work in two different worlds, in other words, to have them have collaboration, share ideas, share electronic medical records, etc. Identifying champions within the organization in order to make a change. Supporting clinicians is another sort of category. For instance, if you're asking a clinician, let's say a primary care clinician, to do mental health screening, all right, how do you actually give them the tools? How do you sort of teach them to use the tools? How do you sort of, maybe perhaps review what they're doing and to sort of be able to relay the information, or really sort of having some clarity around the roles of what you're doing. It is your expectation. We're going to put in reminders. We're going to put a pop-up chart in the electronic medical record. That's a separate category that you might combine. And then, of course, especially in low and middle income countries, there is the idea of utilizing financial strategies. It can be for clinicians. It can be for organizations. We have these things in the U.S. called HEDIS measures, which are quality indicators in a hospital. In order to get the amount of money for Medicaid, you have to achieve 80% across a number of these measures in order to get the full reimbursement. So it's a type of contingency management. It's the carrot or the stick. In some ways, both of them are there. I don't really like the stick that much in implementation science, but the carrot is always a little bit tastier. One of the things that you have to do as part of your pre-implementation stages, you really have to decide what might be the right strategy to use. And what often happens is people say, oh, I think this is a great idea because this is what I like to do. That's not really the way it should be done. You really sort of understand the implementation barriers and facilitators. We'll talk a little bit about how we do this pre-implementation work to guide the strategies that we're doing. So if your providers say, I just don't feel comfortable doing depression screening, you might have to use some education and training, and then once they get started, they might learn it for a little bit, but they might need additional support repeatedly over time. So audit and feedback might be one of the sorts of additional things, or you could do ongoing coaching. So you can choose based upon where folks are. If their confidence is poor, it might require educational training about clinical work, whereas otherwise, if it's just that I feel like I'm already doing this and they're not, really audit and feedback might sort of need to sort of work. But it's also important not just to look at one group of stakeholders. You need to understand what's happening in the sort of the legal or the policy framework, all the way to what's happening at the patient level. Because those kinds of barriers and facilitators are oftentimes what results in these multi-component implementation strategies that we're sort of choosing to use. And I will make the argument that, that the socio-ecological model is one of the ways that we might want to sort of think about, giving us a heuristic for how we're going to sort of really select them. And this is a lovely model. If you can go online and you can type the socio-ecological model, and it will show you some variations. But this is like one example. So you've got your public policy. What are the state regulations? Oh, I can't do this because the law won't let me. Or the guideline says I can't do this. What's happening in the community, the relationships between organizations and hospitals and government, and how do those work in those kinds of settings? What are some of the way that organizations are sort of siloed, how they have their policies and procedures? Those sorts of things are important. Remember that the patients, where you really want to have your efficacy outcomes if you're doing these hybrid trials, they don't live in a vacuum. They have relationships. They have relationships with their clinician. They have relationships with their family. They've got peers within their social networks who all may have an impact. And so really understanding those multi-level barriers is really helpful because it will help you in the selection. And I know that you're going to say, well, how do I select? And it's going to be the infamous black box that we often talk about as we try to think about this. So what's happened is that we do our pre-implementation work. We understand what the implementation climate is, what is the organization, what's happening for the patients, what's happening with the providers who might be very busy. Understanding what those barriers and facilitators are that are sort of driving, or they may be some resources within the community that you can take advantage of. And then, of course, you know, is there executive sponsorship? Is there leadership, whether it's from the government or the organization that says this is something that we want to do? And importantly, and increasingly importantly, does that executive leadership actually say that in a way that people know that they're allowed to make these kinds of changes? Is really, really important as part of this. And this black box is how do you put all of that in, and for the selection of strategies. And for many of us, we sort of work with these taxonomies. We've gotten fairly good at that. But for those of you who might be just starting and thinking about that, is there is going to be sort of a tool that I'm going to get at that might help you. And it's an interesting exercise, I think, that might be sort of useful. So what I like to do is I think that Rasta sort of talked about these implementation gaps. Cascades are really great ways to think about that. What do we want to do in order to narrow that gap along the way? And I would say that if you've got a gap where you've got, let's say, 90% of people who were tested, but on antiretroviral therapy it's only 68, go for the big important things. Go where the money is, if you will. And so sort of thinking about the sort of the relevance that Donna talked about in her 3 R's. And then, so think about what's already out there in terms of implementation. For example, if you've got a referral to treatment in someone who's diagnosed with HIV, what's going well with it and what could be improved or not? I'll give you an example of this in a second. What are the implementation strategies that might need to be layered on to the existing standard of care? And might it be just education and training that is doing it better? Or if the clinicians aren't doing it, do you use something like audit feedback in order to give reminders when people are too busy? Now, there are some very complicated ways to think about doing your sort of planning to figure out what strategies, and you need someone with Donna's skills as a biostatistician to do some of this work. I've done probably the conjoint analysis myself, but I've not gotten beyond that. I really have to go to people who are much smarter and more able than I am, but there's sort of concept mapping where you'll map out the resources and the barriers and the facilitators and try to figure out where that is. There's group model building, and the concept mapping is typically mixed methods that's used, and so that's one of the reasons why I think it's important to have a number of different skills available to you. A group model building requires a little bit more statistics, and it actually shows pathways by which certain things implementation may be impacted. And then conjoint analysis will present an array of potential strategies, and it may be to clinicians, and they might, audit feedback might work with this particular thing. It's very, very strong because it really sort of involves patient preference, or not patient, but let's say clinician preferences along the way. The problem is that the preferences may not align with what what's actually needed. So that's one of the limitations of conjoint mapping. And then I would say probably the most complex, at least to me, is the intervention mapping, which really does require some advanced biostatistical skills. And in the slide set that I'm going to leave, I've got each one of these depicted with a lot more information that you can go to. But for those of you who really want to just figure out how to move to things very, very quickly, we'll learn a little bit tomorrow about the consolidated framework for implementation research. We call it CFIR. It's one of the sort of the implementation frameworks that's often used. And they have a really complex website that is just terrific to use. And what you can do is you can go to their main web page. You go along the bar across from home, go over to strategy design. This is how you help select your strategies in order to do this, and it maps the 73 implementation strategies in the 9 clusters that were described previously in terms of which one may give you the most by putting in the inputs of what is known about the barriers and facilitators. And what you have to do, it's free. You just have to go in and sign in and get registered in order to use this. And it will go through a series of barriers and facilitators and resources that you will have done as part of your landscape analysis. So it can actually help you potentially select, and of course you have to sort of know a little bit about them in order to see if that has some face validity in terms of its use. Now, one of the things about the implementation strategy is you have to get it right. You need to be able to specify it clearly and really make sure that you're recording it. And I use this as my template for how I'm writing my grant as well. All right, so you have to be able to name it. So name the strategy. I'm going to use audit and feedback, or I'm going, by the way, all these slides are available to you. This is a figure that took right from Noel Proctor's paper, so you can have it, but you can take pictures too. Just make sure you give me hair whenever you're doing the workshop. So you have to name the strategy, try to use the language that's in the taxonomy, the ERIC taxonomy, if you will. Define it, okay? Make sure that it is going to be really, whether it's going to be a discrete or a multi-component strategy, and specify it in the following ways. And the terms that they often use is the actor. That is the person who is going to be doing the thing. The clinician is going to be doing this action. Okay, they're going to be doing that on the target, which might be the patient, or it might be the organization on the clinician. So you have to sort of, make sure that you know that there's the actor, the action, and the target. How often it's going to be and when. And of course, if you don't do that at those particular times, there are statistical methods that Donna will tell you about. We can get her to get back up on stage about how you fix that whenever you sort of either change those things or people don't adhere to that kind of fidelity that you need. The dose of it. Are they getting what you're supposed to do when they're supposed to be doing it? What's the implementation outcome that you want it to do? In other words, if you're using audit and feedback, do you expect it to sort of really increase the likelihood that the clinician does screening from point A to point B if they have X number of audit and feedback sessions over this amount of time? And then really justifying why you're using that. And one of the things that I would say as part of the justification is really identifying, can you use lower intensity interventions, strategies versus higher intensity strategies. And we'll talk a little bit about what they look like. So let me just sort of take you to a study design. As Donna said, everybody wants to do a type 2 hybrid. This is a cluster randomized trial. This is a study that we just completed. We've got some preliminary data on it. And we really did some stratification up front. And this is to really sort of integrate HIV, TB, and addiction treatment into primary care settings. This is in places where the clinicians don't know anything about these sort of 3 specialty diseases. We knew that patients who were new on methadone were going to be different in terms of their outcomes relative to those who were not. So we did a stratification, and then we did allocation to either get the treatment for the addiction care and HIV and TB in a primary care clinic, or to be in a specialty care setting. And then one of the things that we did was we did some pre-implementation, and the clinicians did not have confidence in terms of what they were doing. So we really wanted to build confidence in the clinicians. So we used something called Project Echo. You're going to learn a lot more about that from Dr. Haddad And we sort of created that, and we defined it so that there was tele-education and support and some elements of collaborative learning that occurred between clinicians over time. And then the second component was pay for performance, which is a financial incentive strategy for adhering to preset guidelines for improving health outcomes. And I'm going to talk through what we actually did and we specified in order to do this. So we named it pay for performance for physicians. Sometimes you'll hear the word conditional cash transfer. That's often used. So these are sort of interchangeable terms that are often used. Define it. They were predefined so that people knew the amount of money they were getting for each primary care and specialty care service that was delivered to the patients. The actor was the payers. We did it as part of research, but it eventually moved to the government to do that. That was one of the changes in our designs. The action was they got paid a certain amount for each indicator that they achieved. The target was on the clinicians. All right. The temporality was that we measured the outcomes and paid them every 6 months. We told them how much they were getting, so the amount per indicator, and they would get a bonus if they achieved that HEDIS measure of 80%. So all of those had to be clarified up front. The implementation outcome was whether they got a certain percentage of the clinical indicators. And part of our justification was we were doing this in Ukraine, where the average physician payment per month is $250 US. So they were just underpaid. They had zero motivation to do anything more. And would the behavioral economics or the incentives actually sort of make the change? And so this was an example of how we defined it up front and the way that we're going to measure it overall. Now, some of these implementation strategies are much, much more intense. And so you have to sort of think about that intensity, really trying to use the lower intensity ones first. And then if you're not getting your outcome, sort of really maybe perhaps build on that with regard to things that are going to be more efficacious. So some of the examples of like what we would think about sort of tailoring some of these strategies based upon the barriers is if we knew that the target for the strategy was that the person or the people within the setting had a lack of knowledge, we might use some interactive educational sessions. So there's a bunch of them that you can use within that. What if there is a perception versus a reality mismatch? You go to a whole group of clinicians, they say, yeah, I screen everybody. And in reality, you find that it's 40%, right? So you might use something like audit feedback or expert coaching or expert intervention in order to help people sort of remind them to do that. You could have a pop-up screen on your electronic medical record to remind people for every person they come in. So these are some examples when there's a perception versus the reality mismatch. And that often happens when people are very busy and they don't feel like they have the time to do that sort of work. There may be the lack of motivation. I'm already getting paid this amount of money for this amount of work. Why would I do anything more? Incentives, and like I said, I'm not really a fan of sanctions. There are some places where it works, but I think the carrot is much better than the stick. Beliefs and attitudes. And so if you're trying to really use an evidence-based practice and people aren't that invested in it, I do a lot of work with methadone and buprenorphine treatment and addiction treatment settings. And clinicians say, I don't want to do that. I don't want those kind of patients in my sort of clinical practice. Using peer influence, opinion leaders might be a way to actually get them motivated so that they can get those kinds of rewards. Collaborative learning can bring people together so that they can actually be sort of supported by other colleagues within the teams. And then the systems of care. How do you actually sort of process redesign? So one of the examples is let's say, for instance, you have this whole sort of process where you've got your guidelines, say that you do 50,000 things before you get to the final output. I always will tell people, if you show me what your protocol is and I can't read it, there's a problem with your process design. So you need to redesign it and simplify it, and that may be one of the ways that you sort of use an implementation strategy. I'm going to sort of move beyond some of this because that's really many of the things that I've already said. But whenever you're tailoring your implementation strategy, and I will say that the tailoring is important because it's what you need to do in your context. Like in other words, you might need, let's say if you're doing a sort of a coaching call, you might need
bit, but you sort of need to understand what's locally driving some of these issues, identify the change method, and to address those determinants, and then to develop or choose strategies to overcome those sorts of barriers. So that will be really important with the sort of resources and tools that you might have available. You might need to tailor it. If people don't know how to ask questions around depression, you could do sort of a pop-up so you could up on the screen. You could actually give them to your site, and you might like to tailor it and say, our clinicians don't have time to do this. Maybe we can do this while they can scan a QR code in the clinics. There may be other ways in order to tailor to your context. In a sort of the ERIC tool, the Sphere online tool, one of the things that they've identified is what are some of the most important factors influencing the selection of an implementation strategy. And there's the sort of not very important to somewhat and extremely important. But the relevance is probably the single biggest factor that drives the selection. So does the strategy have direct relevance to the bear? I just am too busy to do this and I forget. Would an audit help? A pop-up screen help? So in other words, is it going to directly address the issue that is stated? Is there an opportunity for improvement? Will this have a big impact? So things like audit and feedback in general have about a 4% benefit. They're very small, but they can be really important and they're low intensity. So that's a little bit less prioritized in terms of selecting. Feasibility, can it realistically be done? Or is it really take a mountain of work in order to do that is the third most relevant factor. Validity, is there really good evidence for this? And we're getting better at looking at some of these things, and I'm going to show you some results of a systematic review in terms of which ones may give you the most benefit, but they may vary for different conditions, and so you can't throw them all out, but that's actually much less important. And then the level of difficulty, in other words, what are the work and the resource constraints in order to do that implementation as less. So here is a sort of a meta-analysis of the use of clinical practice guidelines for implementing strategies in public health. And there are a lot of studies, there are well over 100 studies that go into this. And one of the things that they did was they looked at, is it a single strategy, so use as a single strategy, and did it have a benefit on the process of that was actually it set out to do? Was it part of a multifaceted strategy? And then did it have an impact on the patient as a multifaceted strategy? And audit and feedback really did not have much of an impact across any of these things as a standalone, which is why it's a very useful tool, but it may often need to be combined with something else. Organizational culture. Is the culture change around the way that you do certain things? This actually has an impact both for as a single process, multifaceted strategy. It really hasn't been tested to see whether it has a multifaceted strategy outcome. Some of the emerging trials on integrated care may actually sort of change this calculus a little bit. Educational interventions, we'd like to do these all the time because we really feel like education, but typically alone, they don't have a whole lot of an impact overall, but they do much, much better once you start getting them into multifaceted strategies for not only certain diseases that impact the patient, but also on the impact on the processes. Patient-directed interventions have a mixed sort of outcome, with most of the benefit being a single strategy for physician adherence to guidelines. So there is some benefit for that. Reminders have an impact on, as a single intervention, on physician adherence to guidelines. So those reminders, did you do this, might be sort of a pop-up screen, but less so as part of multifaceted interventions for patients and for processes. Educational meetings itself, we often travel to many places around the world, and it's meetings, but it probably is not going to be your driver. You've got to do something to change the processes. If you don't change the way that you do it, all the education in the world isn't going to have an impact. Academic detailing, having an expert come in and sort of talk to you about what you're doing. A lot of times there's a mismatch between that strategy Many clinicians are arrogant. I'm part of them. We don't like to be told what to do, and so there might be a mismatch in terms of what it is that we think that might be good, but also the way that the academic detailing occurs. Let me give you an example of a behavioral intervention. It's an evidence-based HIV prevention for young men who have sex with men. It's got 5 modules as part of it. The standard strategy was an in-person delivery through community-based organizations. And the trial that they did was they were trying to figure out, we can only get it to people who are willing to come into our community-based organizations. So there's issues around stigma, there's human resources, and also having to retrain the deliverers so that you have tons of people who do this. So these were some of the things that were sort of identified. So the alternative strategy was, well, and COVID came along, can we sort of move this to online? And so, so one of the ways that they sort of designed this was as a type 3 trial. Remember the processes, the implementation outcome is primary, and they measure some efficacy outcomes. It was a cluster randomized trial, and they did it by counties. So when Donna was talking about these groups, they got certain counties that had CBOs and those who did not as part of that, and they had some efficacy outcomes, which were HIV risk behaviors. This is what was shown in the original studies. And then whether they went on from risk behaviors to engaging in prevention. Then for the implementation outcomes, however, they looked at the fidelity to this 5-module, 1-hour session that happened. They looked at the number of modules they completed, the level of engagement, did they interact, how much time did they spend, and they had to do something a little bit different because it was online. So they had to look at the online heuristics of interacting with the online tool, and then they looked at stigma satisfaction and cost effectiveness. So you can see that they sort of identified what the problems were. They came up with some strategies in order to overcome this online delivery, and then they're doing a number of things because you can have an expert who is doing it consistently over the same time, where you might get that sort of higher level of engagement. You might get a higher level of efficacy in terms of the fidelity, but you may not get the level of interaction, so people may not be confident. So you have to sort of measure those in order to see if you have the outcome. Here's another example that is done in sub-Saharan Africa. This is ADAPT for adolescents. These were sort of young adolescents with HIV who were 14 to 24 years. The implementation gap was that these individuals, once they got tested, did not get linked to care and did not remain in care. We sort of know that a group that's under 25, they just don't engage in anything except for maybe social media that much. And what they did was they looked at the standard of care, which was education and counseling. So we're going to do our HIV test, we're going to give you some education and counseling and refer you to treatment. And they wanted to say, all right, if we have a setting where the youth don't really want to talk to people, they don't want the stigma of the in-person visits, can we do this through online navigation in addition to that sort of standard of care? And they sort of randomized them to this, and we're going to get to a different design that Donna didn't get to, but it's really called a SMART design. And what they did was they sort of took a look at folks over the first year, whether they lapsed from treatment, that is, they either dropped out from care or they got virologic failure. And remember, the first intervention is this e-navigation. It's not a very intense intervention, all right? It's just a little bit more than the standard of care. So you're comparing those two up front. And then what they did was they took a look at people and they said, all right, did you fail in terms of the treatment? And if the answer is yes, you would get re-randomized with the idea that we want to eventually achieve viral suppression or not have them drop out for care. But what this trial does is it says that if you don't fail, you don't need to do a whole lot more work. All right? You've reduced the amount of work that you have to do. You don't have to do intensive case management and all kinds of other sorts of things. But if you do fail, it means that you sort of need to step up your implementation strategies. So what they would do is they would have their sort of usual standard of care outreach and intensive counseling. So they would go and track down people in the community and bring them in. Conditional cash transfer. It was expensive for these young people who didn't have a lot of money to come into clinic, and so they paid them in order for achieving, a visit to a clinic that they could document and achieving virologic failure? Those were set and pre-specified. Or do they do in-person patient navigation? So they move them out of the virtual space. So we're moving into some of the higher level ones. So you end up with 6 different ways, and you can combine them depending upon the randomization, whether people sort of failed the initial part over the second year and came up with an outcome. And one of the problems is that they had to face in this study is that if the individuals failed to take their medications, well, they might actually develop resistance. So they might not actually develop virologic success down the road because they would have already have failed the treatment. Now, there are a number of facilitated strategies for integrated care. We could choose any sort of disease, but we actually have a systematic review for integrating alcohol and other drug services into other settings. And it's a systematic review of 14 studies. And what they really wanted to ask in terms of the question is what factors, strategies, that is, contribute to improved integration of putting these into other services. In other words, they're saying, all right, you're not skilled in doing this, but you're now going to have to do it. What are the factors or strategies that contribute to improved integration, such as mental health, primary care, housing, and others? And then what was the landscape? What were the barriers that was sort of undermining the ability to do this? Oftentimes, this was in California, and when people would get serial treatment, they would say that you need to do this before you can do this, and they would not treat another condition until their alcohol or other drug condition. We saw this with hepatitis C as an example, that you had to achieve sobriety for 6 months before you could actually get sort of treatment. Siloed healthcare delivery systems. We pay people in different pockets of money for primary versus behavioral care. And so there was a lack of coordination. These two places would happen often independently. And then there was certainly a lack of training and support. The primary care clinicians just did not feel like they had the confidence to screen or to treat for any of these conditions. And so some of the strategies often targeted several levels and sometimes in combination in this study. And so one of the things that they started to do when they looked through all of these various different studies is they tried to organize them along the socio-ecological model. Did they do it by selecting strategies that affected funding, administration? There wasn't really any organizational service delivery for those that impacted the patient. And they broke them into several different groups, such as system investment. In other words, you'll see a study when one of the things that they did was they ended up sort of co-funding treatment so that you could get both services on the same day. Executive sponsorship, there wasn't really much that looked at that particular one. Co-location of services was one of the more common strategies that they used in order to bring these services together. These were in primary care settings, so they oftentimes will have other folks that are available to do some of the task shifting. Staff training, such as information sharing. Oftentimes, a clinician who's doing primary care wants to see what's happening with the patient who's getting the behavioral health care and vice versa, so that they can see the impact of one on the other. So there may be many other different sort of strategies within that. And then for the clinical service delivery, did they have screening practices? Did they have the tools that they need? Were there joint care planning? In other words, were the teams coming together and doing dual case management? Or was there staff supervision for the clinicians who felt like they were unable to do that? So one of the better studies looking at funding or system investment is that the billing did not allow for clinicians to get paid for doing both on the same day, so that there was no incentive to do that. Same-day billing was not allowed, so they would make them come back a second time. But if you have a substance use disorder, your likelihood of coming back for another visit is much, much more complex, and so that's reduced. And there was a lack of alcohol and other drug support services in the community. They just didn't have it, so it was really reliant. They didn't have a place to refer patients to. Some of the suggested strategies that they looked at was a change in the reimbursement. So they just changed the funding cycle so that you could actually have same-day billings for ICD codes, ICD-10 codes for both physical and behavioral health. And then they provided state block grants to support some of the community services. So they had a couple of implementation strategies that then resulted in more patients getting seen and treated through these various different activities. Co-location of services is what you do at the organizational level. Many of these were primary care settings, and they already had social workers who within that, so they did some task shifting so that they could actually see the patients. They set up a time so that the social worker would have one day where they would do their urgent referrals, and then they would have to deal with their other caseload on the other days, so they reorganized the way that they did their work. And then also one of the other barriers was that the primary care providers did not have the confidence to do that work. So one of the strategies that was implemented was supporting the clinician by assigning the social workers who were already busy to have one day free where they did not see their regular patients. They would just take the patients who came in on the day of the referral. They gave them role clarity. They says, you do not have to see your regular patients on Tuesday, but you have to see them all the other days. But on Tuesday, you're going to take the new patients who come in and who need to get seen. They did some training and education, and they had to make some decisions around whether it was a single training versus sustained training to really build confidence over time. And then they gave some audit and feedback, and that resulted in increased alcohol and drug use services that were being delivered to patients in primary care. Sort of moving on to service delivery models, information sharing. Remember, these were two siloed places. The primary care physicians were unaware of how the patient was doing with their behavioral health, and vice versa. So a person might have diabetes that was uncontrolled, and their substance use disorder was having them eat snacks and really sort of not managing their diabetes medication. So they didn't know how to sort of link and have a shared responsibility around the patient. So some of the suggested strategies for that would be case coordination of sharing of information, which is a type of collaborative learning, and shared notes through the EMR where they would target the note to get to the other person so that they could learn. So they identified the barrier, and then the implementation strategy followed for that. And then in terms of the clinical level, down to what happens between the provider and the patient, the clinicians just didn't feel comfortable in screening or treating. It took too long for their busy day to add one more thing onto it. And they were also felt like they had to really screen for too many things all at once. And there are these tools that really try to do everything, but they're really cumbersome and clunky in clinical practice. So one of the things that I would say for many of these things is try to keep it simple if you possibly can. So some of the strategies were to train and educate clinicians, either one time or initially. Use a QR code and let patients screen themselves. There's many sort of self-screening tools that you can use, and then have feedback to the clinician. Train and task shift. Can the medical assistant do the work rather than the clinician or the physician? Use simple, broad-based screening instruments. Make them as simple as possible. I will have people say, oh yeah, we're using this great screening instrument. It has 22 questions. I said, that'll never get done in primary care. So you have to really make sure that you tailor it to the environment that you're working, and then audit and feedback by DOA. So if I summarize at this particular time point, we do need implementation strategies, but we have to get better at it. There are still big black boxes with how we do the work. We've got that CFIR ERIC tool that's online to help us with that, but we sort of need to think about it. They're getting complex, multimodal in terms of what we do, and the timing is one of the factors that is involved in this. And we need better tools to identify and select the right ones. And I think that as we sort of move towards this taxonomy and sort of mapping things out, we're going to get better at it. But we're also going to need to get bigger, faster, and smarter about how we do it, including combinations across multiple levels of the socio-ecological model. Thank you so much.
Wish we could hear more from Prof. Altice. If you have questions or you want to discuss with Prof. Altice will be more than happy to discuss with you over the lunch break. And all of the slides and video recording will be uploaded in CBP and GRIA's website. A digital library will be created, and you'll find all of the slides in CBP and GRIA website. Professor Kaveh Khushnud, an eminent public health expert and epidemiologist, is our next distinguished speakers from Yale School of Public Health. Prof. Kaveh Khoshnood leads the undergraduate program at Yale School of Public Health. Please welcome Prof. Kaveh Khoshnood.
Hello, everybody. I want to thank Professor Altice and all the Malaysian colleagues for inviting me. And thanks to all those who organized this ceremony. The topic of my presentation, as you can see, is implementation science in humanitarian crises, challenges and opportunities. I have been involved in research in humanitarian setting for about a decade. But the topic of implementation science in humanitarian setting is a new topic for me. When Professor Altice invited me to this event, I did some research on this topic and came across very few articles. Most of the papers were commentaries and review articles. So it seemed there has not been much implementation science research in humanitarian settings. I will share with you what I have learned so far, which I hope will be useful for you. I also know that there's a lot of people here who have comprehensive knowledge and expertise in implementation science, and I'm really excited to learn from you. I've already done so. I'd like to acknowledge Sydney Jones, our recent MPH graduate student who helped me put some of these slides together. My academic background, I'm trained as an infectious disease epidemiologist, and my work started with HIV/AIDS, going back to my PhD training in the early 1990s. At that time, I was involved in an evaluation project of the pilot syringe exchange program in our city of New Haven in Connecticut. This evaluation project was certainly not an implementation science research, but we were delighted that after a year that we released our report to policymakers, they made an important decision to change the syringe access restriction laws that allowed access to syringes over the counter from all the pharmacies. My second research interest has been focused on ethics of HIV/AIDS research with vulnerable populations in the United States and low-middle income countries. This interest was triggered by our own research team encountering multiple ethical issues when we were conducting a US-based HIV/AIDS research with community-based active injection drug users. Ethical issues of conducting implementation science research in humanitarian setting is certainly an important topic and is part of my current research. Over the last 10 years or so, I have become focused on addressing health of populations affected by humanitarian crises. This is a very personal topic for me that I've wanted to focus on for many years, and it took me some time to feel more comfortable to address it. So here's the outline for my presentation. I'd like to start by telling you a little bit about my humanitarian research lab. Then I will briefly share some of my HIV/AIDS studies in humanitarian crises. Third, I will share with you what I've learned about implementation science in humanitarian crises. And the last outline is to mention the case study that my colleague, Professor Helen Skuteris from Monash University, and I will be discussing at a workshop tomorrow afternoon. Many definitions of humanitarian crisis. This is one of the most frequent popular one. Humanitarian crisis, an event or series of events that represents a critical threat to not just to health, but to safety, security, or well-being of the community, or other large groups of people, usually over a wider area. Humanitarian crises are usually put in two broad categories. One is climate crisis, the other one is armed conflict. And unfortunately, some of the countries go through both of them. By the end of 2023, over 117 million people were forcibly displaced as a result of persecution, conflict, violence, or human rights violations. And over 26 million people were displaced due to weather-related and geophysical disasters. I launched my humanitarian research lab in 2021 at our School of Public Health, and I'm going to tell you a little bit about the mission and objectives of our lab. So here's the overall mission. It's to support humanitarian organizations and policymakers to address humanitarian crises. And our lab has two broad objectives. First is to produce evidence for human rights violations during armed conflict. And second is to address the health needs of populations that are affected by humanitarian crises. My team is involved in a U.S. State Department-supported project called Conflict Observatory. The State Department launched the Conflict Observatory project shortly after the Russian invasion of Ukraine in February 2022, with the aim of capturing and analyzing evidence of war crimes and other atrocities allegedly perpetrated by Russia. The approach for this work is to analyze and preserve publicly and commercially accessible information, including satellite imagery and information shared via social media that can be used in ongoing and future accountability mechanisms. This work requires a lot of expertise in geospatial analysis, and I'm fortunate to have a team who's been doing this for many years. In June 2023, the State Department launched the second Conflict Observatory project to document war crimes during the ongoing civil war in Sudan, which began in April 2020. My team has been involved in that project as well. The Sudan project involves similar analysis of open source data, including satellite imagery, to document war crimes. By the way, I have been thinking about whether studies that involve geospatial data analysis are sort of implementation science type research, because certainly they're meant to have policy and practice implications. And an increasing number of environmental scientists are heavily involved in geospatial analysis for monitoring and mitigating climate crisis and its effect on human health, which can be also very helpful. Maybe this is something we can discuss later. So our lab, our humanitarian research lab, has been putting out dozens of reports over the last few years. And these are some examples. For example, we released a report on attacks on healthcare facilities and schools by Russia's forces in Ukraine, a report on filtration system and campaign of extrajudicial detentions and disappearances, damage assessment to Ukraine's crop storage infrastructure, potential mass graves in Ukraine and Sudan. And I've highlighted one of the reports that I think has had the most impact. That is Russia's systematic program of transfer and deportation of Ukrainian children. A month after we released our report on Russia's abduction of Ukrainian children, the International Criminal Court president announced indictment for Russia's President Vladimir Putin and Child Rights Commissioner Maria Lvova-Belova. It's not something we were expecting, but it certainly got a lot of attention. The second objective of our lab, as I mentioned, is health of populations in humanitarian settings. In this slide, I've sort of listed a number of health projects that I've been involved with. One is HIV/AIDS in humanitarian crises. I've particularly worked in Lebanon and Northeast Uganda. Substance use and mental health of forced migrants from the MENA region. Verbal autopsy project in Northwest Syria, which is a conflict zone. Cancer care for forcibly displaced population in the MENA region. And ethics of conducting research with conflict-affected populations. So next I'm going to talk to you about HIV/AIDS in humanitarian crises. This is certainly something that needs much more attention, especially given the rise of conflicts globally. Addressing this issue is essential to fulfill the promise of ending AIDS by 2030. I should also mention that the evidence of association between armed conflict and HIV infection has been conflicting, with some studies showing a reduction in HIV/AIDS cases related to armed conflict. Others have found either no association between conflict and HIV prevalence or insufficient evidence for the same. This has led to an understanding of conflict as a potential risk factor for increased incidence of HIV infection, whose effect may be mediated by other factors in the causal pattern. I want to tell you a bit about my HIV/AIDS work in two humanitarian settings. I mentioned Lebanon and Northeast Uganda. This slide shows some of the manuscripts we published on our HIV/AIDS work research in Lebanon, with a particular focus on the Syrian population, especially men who have sex with men, who were forced to leave their country and arrived in Lebanon. In the interest of time, I think I'm only going to share one of our HIV/AIDS studies in Northeast Uganda, which I think may be more aligned with implementation science. The conflict in Northeast Uganda is in its 13th year. Approximately 400,000 people, around 50% of the population, are internally displaced. The rural economy is catastrophically reduced. I'm going to tell you about one of our papers, which is on the top right, that focused on transactional sex work and HIV among women in Northeast Uganda. This project was led by my former postdoc, Dr. Jennifer Moose. We were aware that the evidence of association between armed conflict and HIV infection, as I mentioned, was inconsistent. Some studies reported that exposure to armed conflict elevates HIV infection, and others claimed the opposite. The objective for this study was to examine the role of mediating risk factors, such as engagement in transactional sex work, to elucidate the relation between armed conflict and HIV infection. Transactional sex work has been proposed as one of the mediators of the relationship between conflict-related trauma and HIV infection in post-conflict settings. And transactional sex work refers to non-commercial sexual relationship with a component of intimacy where sex is exchanged for material gain. This informal exchange of transactional sex can occur for cash, food, clothing, transport, items for family, housing, school fees, etc. This study aimed to qualify the mediating effect of transactional sex work on the observed relationship between exposure to armed conflict and reported HIV-positive serostatus in 3 districts in Northeast Uganda. We had hypothesized that armed conflict would associate with reporting HIV-positive serostatus, and that transactional sex work would indirectly mediate this association. To our knowledge, this was one of the first population-based studies from sub-Saharan Africa to examine transactional sex work as a mediator in an indirect pathway between exposure to armed conflict and reporting HIV-positive serostatus. I'm going to tell you some of the conclusions from this study. First, although exposure to armed conflict was associated with reporting HIV-positive serostatus, this relationship was not mediated by engagement in transactional sex. Further research is definitely needed on risk factors that mediate this relationship. The likelihood of reporting HIV-positive serostatus increased with each additional type of exposure to armed conflict, such as age and residence. For example, older women residing in high conflict districts were more likely to have reported HIV-positive serostatus than women residing in districts with less exposure to conflict. Thus, screening for exposure to multiple traumatic stressors should occur in HIV prevention settings. And healthcare services that are trauma-informed and consider mental distress would likely improve health outcomes. After completing one of our studies in northeast Uganda, we had a discussion about dissemination plan. We were definitely concerned that releasing such sensitive data may potentially further stigmatize these women in conflict-affected northeast Uganda. We searched to find if there was any guideline on dissemination of such a sensitive topic from WHO or any other global organization, and we couldn't find any guidelines. So Dr. Jennifer Moots and I spent a few weeks in Uganda discussing the dissemination plan with key stakeholders, in particular the NGOs that offer services to population in this region and were involved in our research. And we kind of came up with half a day community-based dissemination events where study results were shared with the community. And we also kind of came up with some quiz exercises that they actually enjoyed. For example, we asked quizzes such as, what percentage of male partners of women participants do you think drink alcohol? And different people said different answers. We recognize that the humanitarian researchers may encounter same ethical challenges that we encountered, and we decided to publish this study. The next project is a scoping review on factors associated with HIV acquisition in the context of humanitarian crisis. Dini Harsona, who's my colleague and is leading this project, actually just presented this scoping review at the AIDS conference 2024 just a few weeks ago, and maybe some of you were there and heard this presentation. So basically, we wanted to know what are the factors associated with HIV acquisition in the context of humanitarian crises. And we did this scoping review. We are not completing yet. We haven't published it yet, but we are about to. And given the knowledge gap that I mentioned, our team set off to conduct a scoping review to explore what's the global evidence on factors that are associated with HIV acquisition among people affected by humanitarian crises. And then we had these two aims. One, to summarize the research on HIV risk factors among people affected by humanitarian crises, and also identify recommendations for further research and practice. These were some of our findings. We only found 49 studies published between 1990 and 2022 on this topic. 5 had non-modifiable and 60 had modifiable factors mentioned in their papers. And when I say non-modifiable factors, I'm talking about age, gender, ethnicity, location, place of birth, or origin. When I say modifiable factors, I'm talking about any factors that are not biologically or socially determined and can potentially be modified through policy or intervention, such as policy and structural issues, sociocultural issues, health, mental health, sexual practice, etc. Our other finding was that of these 49 studies, only one was an actual intervention, had an intervention component in it. There was no other HIV intervention study in humanitarian setting. And then we made some recommendations for future HIV prevention program and research. Why is that important? Because in 2024, nearly 300 million people globally are impacted by humanitarian crises due to conflict, climate emergency, and other drivers. The complexity in assessing the impact of crisis on HIV epidemiology is imperative. And the importance to address multi-level risk factors to optimize HIV prevention is also needed. So I really do think implementation science to tackle HIV/AIDS in humanitarian setting is absolutely crucial. Now I'd like to discuss the key topic of implementation science in humanitarian setting. And as I said in the beginning, this is a new topic for me. And to prepare for this presentation, I learned as much as I could from reading the papers that are published on this topic that I'm going to share with you. Now, before diving deep into implementation science in humanitarian crisis, I'd like to briefly go over this paper, which also made a very strong case for the importance of health research in humanitarian crises. The authors did not mention the role and contribution of implementation science in humanitarian crises, but I found that some of the questions they raised was actually relevant to implementation science. And here are the questions. They started with this sort of big question of what is the role of research community in addressing the health impacts of humanitarian crises? And then they came up with these other questions, such as how can research improve the quality of health services during and after a crisis? Are there important scientific questions that can only be addressed by research in these contexts? How do researchers work in these challenging settings without impeding humanitarian assistance and ensure that research findings benefit affected populations? How are successful, equitable, and sustainable research collaborations built with local researchers in humanitarian settings? And the last one, is there an advocacy role for health researchers? So now I'm going to be presenting 3 papers that focus on the topic of implementation science in humanitarian settings. And as I said, almost all these papers are either commentaries or review articles. They're not intervention studies. So this is the first one I came across. Carrying out embedded implementation research in humanitarian settings, qualitative study in Cox's Bazar in Bangladesh. Basically, the purpose of this qualitative study paper was to assess what are the challenges of implementation research and program implementation within a primary healthcare center and health post and refugee camp in Bangladesh. Just a little bit of a background and history. As you know, as of January 2019, over 900,000 Rohingya refugees resided in sub-districts of Cox's Bazar in Bangladesh. Despite substantial progress during the last 2 years, Rohingya refugees in Bangladesh remain in precarious situations. There's poor living conditions, lack of safe water, sanitation, hygiene, high rates of child marriage, lack of support for education, poor health care, and lack of livelihood. These are major concerns for them. More than 55% of the Rohingya refugees are women and children, many of whom have faced gender-based violence, abuse, trafficking, malnutrition, and serious health problems. Utilization of skilled maternal, newborn, child, and adolescent health services is very low among the Rohingya refugees. Considering this overall situation, UNICEF, in collaboration with Grak University in Bangladesh, undertook an embedded implementation science project with the aim of strengthening maternal, newborn, child, and adolescent health program in Cox's Bazar district. And the main objective of the project was to identify key implementation challenges of doing that, explore potential solutions, and ensure utilization of those solutions for effective implementation of this program in the camps through engagement of decision makers and program implementers. In addition, one of the objectives of this initiative was to document methodological and operational challenges of conducting implementation science research in humanitarian settings. The study mentioned the challenges and lessons as well as knowledge gaps about implementation science in humanitarian settings. They mentioned that despite the growing body of evidence in the value of research in emergency settings, there's still a knowledge gap regarding challenges of conducting embedded implementation research in such settings. And this study aimed to explore the challenges and key lessons learned relating to the design, implementation, and management of embedded implementation research in humanitarian context based on this experience of Rohingya refugees in Cox's Bazar in Bangladesh. So what did the researchers do and find from this qualitative study? Well, they collected qualitative data from stakeholders supporting and implementing health programs in Cox's Bazar. They also conducted interviews with researchers that are conducting a broader embedded implementation research study in Cox's Bazar to obtain their perspectives and challenges in conducting embedded implementation research in such an emergency context. The context of the Rohingya refugee camp was complex, with multiple organizations providing maternal, newborn, child, and adolescent health services, and playing key roles in formulating programmatic and policy decisions for the Rohingya refugees. Health service delivery modalities and policies and related implementation challenges in the camp have changed rapidly since the start of the crisis. And access to the camp, reaching the Rohingya respondents, overcoming language barriers in order to get quality information and limited availability of local research collaborators made conducting embedded implementation research in Cox's Bazar very challenging. They mentioned what do these findings mean? Well, this study may help other researchers understand the potential challenges and identify appropriate strategies for conducting embedded implementation research in humanitarian setting. Implementation research studies with simple descriptive methods that are nonlinear and iterative in nature may be most appropriate to answer real-time research questions and to tackle real-time implementation challenges in humanitarian contexts. Third, when planning for embedded implementation research in humanitarian setting, it is critical to understand the local context and the role of relevant stakeholders, and to identify key decision makers to involve in the project in order to ensure access to camps and research participants, and to ensure uptake of research findings and recommendations. And the fourth thing was that working with local researchers or research institutes with local language capabilities and prior experience conducting research in the context may reduce the cost and time spent and ensure collection of better quality data. This was one of the quotes from the paper that mentioned a key question is whether it is reasonable to do embedded implementation research in an emergency setting, such as the Rohingya refugee crisis, bearing in mind the additional commitment and active involvement in embedded implementation research requires of implementers who are already under significant pressure. So I thought that qualitative study was quite useful for those of us interested in implementation research in humanitarian setting. And then I came across this scoping review, which was just published last year in a journal called Conflict and Health. And as you can see, the question they raised was, how is implementation of empirical research results documented in conflict-affected setting? The objective of this scoping review was to analyze those papers, providing data on processes described by implementation science scholars, and to explore how shaping new practices based on operational research was understood. The authors were able to identify and analyze only 22 peer-reviewed papers on this topic, published between 2011 and 2021. Only 22 peer-reviewed papers. Right, I'm obviously going to be sharing your slides because you can scan this slide to get access to these articles. These were the key findings from the scoping review. That implementing actors are often engaged after research is produced to discuss feasibility. Second, new interventions or delivery modalities need to be flexible. Disruptions affect how research findings can lead to sustained practices. Strong leadership and stable resources are crucial for frontline actors. 5, creating a safe learning space to discuss challenge is difficult. 6, feasibility in such setting needs to be balanced. And the last finding was communities and frontline actors need to be engaged as early as possible in the research process. And they made these recommendations from the scoping. The plan that needs to be flexible, the research program should be flexible and adaptable to the changing and unstable environment of a humanitarian setting. They need to develop task shifting and other strategies to address staff shortages or position transitions within the program, enhancing its success during the organizational transition. One of the key to acceptability of a research program is community support and involvement in the research process. Engagement enhances the trust and foster collaboration between community members and researchers. And the last recommendation was cost effectiveness. Incorporating cost effectiveness measurements into the program agenda to demonstrate the program's impact and support its sustainability. So the last paper, which was just a short commentary, again published in Conflict and Health Journal, 5 recommendations to advance implementation science for humanitarian settings, the next frontier of humanitarian research. This paper was published just a few months ago. And in this commentary, they actually built on the scoping review that I just mentioned to you. And then they came up with these 5 recommendations for advancing implementation science for humanitarian settings. And by the way, when I looked at the authors, these authors were academicians from Johns Hopkins, which has a full center for humanitarian health, as well as academicians from University of Oxford, and leader of the Innovation Lab of International Rescue Committee, which, as you know, is one of the largest humanitarian organizations. It was a combination of humanitarian organizations and academicians. And I'm going to give you a quick sort of overview of this comment. The authors mentioned the key gaps in implementation science in humanitarian setting from the scoping review article that I mentioned. And as I said before, the scoping review article only identified 22 studies that provided data on implementation or operational research process between 2011 and 2020. So definitely implementation science in humanitarian setting is understudied. There's also incomplete data. There's a lack of systematically captured and stored data collection. And there's limited framework. There's limited implementation science framework, models, and theories that account for humanitarian dynamics. So the commentary came up with these 5 recommendations for how we can do implementation research in programs. First, expanding existing frameworks and tailoring them to humanitarian dynamics. Second, utilizing hybrid study design for effectiveness of implementation studies. Third, pilot testing implementation strategies. Fourth, leveraging recent methodological advancement in social data science. And fifth, enhancing training and community engagement. So I'm just going to briefly go over each of these recommendations that they made. So they mentioned that current implementation science framework do not account for conflict-related disruption and its influence on community and service outcomes. And they mentioned that several existing frameworks, like some of my colleagues already mentioned, can be expanded to incorporate some of the gaps that was mentioned before. And they mentioned these 2, REAIM and EPIS. These are 2 examples of framework that have not been used in humanitarian setting, but have the potential to make a difference. The hybrid study design came up multiple times, so that was the second recommendation of basically using hybrid mixed method study design that can also enhance the flexibility in research design and dissemination for different audiences, which is valuable for advancing humanitarian research and action. Reaching diverse audiences and increasing peer-reviewed studies. To date, limitation of the evidence based on implementation of humanitarian intervention stems largely from lack of peer-reviewed studies. So increasing peer-reviewed studies on this topic, I think, is important for adoption, fidelity, and sustainability. The third recommendation was piloting implementation science strategies. Researchers, they recommended should pilot implementation science strategies, should occur alongside the research, help understand what the core components and mechanisms of change result in sort of more easily transferable interventions, and the potential results are that stakeholders can make informed, precise decisions, and increases the trust and partnership across actors. The fourth recommendation was leveraging methodological advancement. Advancement in machine learning, data-driven artificial intelligence could be applied to implementation science frameworks to enable anticipatory humanitarian action, improve accountability and effectiveness of intervention for crisis-affected populations. And they mentioned that these techniques could also be applied to the analysis of non-experimental data to strengthen insights from routinely collected data, enabling better prediction of intervention effects. And then the last recommendation, the fifth one, was advancing training and also enhancing community engagement. Training programs for local researchers who are from and living in the humanitarian setting should be developed and invested to evaluate, to elevate their leadership and advance contextually grounded implementation insights. Also, efforts to systematize practice-based knowledge from practitioners should also be undertaken to promote the role in the design, execution, and dissemination of humanitarian research. And then they mentioned community engagement, which came up multiple times. Service providers and community members should be engaged in the design, execution, and dissemination of research. So when I looked at sort of these three papers, I saw really some common recommendations across these three papers. One, engage with community actors and stakeholders prior to launching a research program in a humanitarian setting. Second, ensure co-sharing and collaboration with community actors throughout the entire research process. Third, develop flexible and adaptable methodology. Fourth, utilize new research methodology, implementation science framework, and theories to improve research in humanitarian crises. So the last thing I want to mention is, as I mentioned, Professor Helen Skuteris and I will be discussing this case study at a workshop tomorrow afternoon. And basically, what we're going to offer to you is sort of a brief sort of discussion about conflict, displacement, and rise of HIV in Myanmar, and how can it be addressed in implementation science. This is not something that, by the way, we have the answer for, but this is something that we want to get perspective from you, and that's going to be our discussion tomorrow afternoon. Thank you so much.
Very much, Prof. Kabe, for the very enlightening talk. It's time for lunch now. Lunch has been served opposite to this room at Damal Masuri. Please enjoy a relaxing lunchtime. We will reconvene here at 1:30 p.m. and we will run interactive workshops parallelly in this room and the room next. If you haven't registered for this boot camp yet, please feel free to register at our register desk outside of this room. Meanwhile, enjoy your lunch. See you at 1:30.